Hi, so welcome, good morning. Welcome to our webinar, Gender Affirming Care. Today is March 31st, 2020. In honor of, Trans Visibility Day, we decided to host a Gender Affirming Care webinar. It's a product of the National Coalition SPD Directors MSM Committee. My name is Desiree Smith, and I'm the Health Equity Manager at the National Coalition of SPD Directors, or NCSD for short. I'm joined by my colleague, Leandra Lacey, NCSD Senior Manager of Capacity Building and Member Engagement, who is also facilitating technical assistant, and you can chat with her via the chat box if you have any questions. And you can also post your questions about the webinar in general inside the chat box for the Q&A session at the end. A bit of a description about the webinar. Transgender and gender nonconforming people face significant barriers to achieving health equity. On March 31st, 2020, in International Transgender Day of Visibility, which is today, NCSD is hosting this webinar in effort to combat transphobia and cissexism. To continue NCSD's work in improving the capacity of our SPD clinics to meet the needs of our transgender and nonconforming clients, presenters will discuss the processes necessary for SPD clinics to identify and meet said needs via community engagement, data collection, programming, and policy. This webinar's objective is to focus on the needs of gender expansive people engaging in care, the unique opportunities and gaps for data collection specific to STD and HIV, and how to engage in program and policy. Just one day short of Transgender Visibility Day, yesterday at 5:22 a.m., Lorena, mother of Queens Borjas, passed away from coronavirus. According to the Transgender Law Center, Lorena saved so many lives from state violence, neglect, and abuse. She fought tirelessly for trans migrants, people living with HIV, and sex workers. To honor her legacy, we will now take a moment of silence. Thank you. On our webinar today, we have Britt Walsh from Whitman Walker Health.
Hi, Britt. This is Leandra. To speak, you have to press *# to unmute your phone.
Hey, good morning. Thanks, Desiree and Leandra, for having me, and thank you to NCSD for taking time on International Transgender Day of Visibility to bring together some tools and resources for this group. As mentioned, my name is Britt. I'm a licensed independent clinical social worker with a background in community health practice. I work as the Director of Gender Affirming Services at Whitman Walker Health in Washington, D.C., and I'm grateful to be with you all today and appreciate that we're spending time kind of reflecting on what it means for trans folks to be visible. And I'll spend a little bit of time talking about what that means in this COVID-19 pandemic. I myself am a transgender, genderqueer person. My pronouns are they, them, and I'd be happy to share any contact information at the end if folks want to stay connected. As Desiree mentioned, there's some goals for this time in talking through the needs of gender expansive people and engaging in care, some unique opportunities for gaps in data collection, kind of what we talk about when we're centering communities and program and policy. But to start, I'm going to go to the top with vocabulary and then just some framing for our time together, talking about cultural humility and strengths-based interviews. So this set of terms, I'll just acknowledge up front, language is changing all the time, but I like to start with this group as there's some pretty uniform ideas of what each of these words mean that I'd like for us to keep in mind as we're talking today. Normally, if I'm giving a training like this, it's interactive, and I'd ask folks, what do you think birth sex means? So forgive me as I just talk a lot at you for a moment. When we say birth sex, we're talking about the sex that a doctor typically assigns someone the moment they're born. When we talk about gender identity, that's the personal, internal identity that someone holds of their gender. When we say gender expression, that's the outward presentation of one's gender, and we use things like our hairstyle or our manner of dressing or perhaps the way we walk or our tone of voice as some of the ways we convey and express our gender. When I say sexual orientation, that is the people that we are attracted to romantically or physically. That doesn't always have anything to do with gender for a person themselves. These next three, non-binary, gender fluid, gender queer, gender expansive, those are not all the same word, but they kind of fit under an umbrella that gets at other ways to speak to transness, that someone maybe doesn't believe they're strictly masculine or feminine. They may be a mix of identities, and I have a slide to kind of capture that in a couple minutes. When I say cisgender, that means that someone's gender identity aligns with what the doctor assigned them at birth. And lastly, when we talk about gender affirmation, that is not strictly a medical thing. People pursue lots of different ways of affirming their gender identity. They might socially work towards affirming their gender identity. They legally may try to affirm their gender, or medically, yes, they may try to affirm their gender. In talking with vocabulary, again, I'll say that language is changing all of the time. So in these slides, there's a lot of words that here but it's not an exhaustive list. Still, it felt important to share some words that maybe we heard decades ago, or maybe you still hear them now. One that I'll highlight, even probably 2 years ago, a lot of places were still saying, well, what are your preferred pronouns? We have pronouns. They're not preferred, they're mandatory. I think there's a lot of memes on social media about that word, and it's not my preferred name. Britt is my name. It's the name that I go by. It's the name that I need you to call me. I'll run through some of these other ones. We don't say the transgenders or the trans. We are trans people. I can't be transgendered, much like other folks can't be cisgendered. I'm transgender. We don't talk about someone having a sex change. Not every trans person would be pre- or post-operative, and that's not how we refer to people anyway. We don't talk about someone being born a man or born a woman or biologically female or biologically male. There are words you'll see at the top of the second column that people in community still use to identify themselves, and that is okay if a person uses these words to talk about themselves or their community, but those aren't words that non-trans people should use to talk about trans folks. Similarly, if I'm talking to any clinicians here, I knew of some surgeons who would approach people and say, wow, I really know why you're getting this surgery. You're a beautiful trans woman. And those are not appropriate things to say. So again, this is not an exhaustive list, and language is changing all of the time. So don't be afraid to, when you hear new words, or if somebody corrects you and says, hey, we don't really use that word anymore. All of us are working to keep up with the times. So when I talked about kind of non-binary and just gender being more than masculine and feminine, these two images at the top I think are really, really common on like bathroom signs. I think for many of us who were socialized in the United States, we see these images and learned that one means man and one means woman. And that's, at least for me, that's how I got a lot of my early cueing of what gender was supposed to be. And over time and in understanding myself and other people, I realized that gender is actually more like the part on the bottom. People, if this is a perfect graphic, the bodies would be moving all around. There would be bodies in wheelchairs and bodies missing limbs and just representation of all kinds of bodies, because gender is not static for everyone. For some people it is, and some folks will, again, stay in place and identify with the gender they were assigned at birth. But keeping this in mind, I'd like for this to be a frame of what we're talking about when we're talking about transgender folks and gender expansive people, is that it's not just man and woman, and it's not just trans man and trans woman, that there are lots of ways that people understand their gender. Another frame for today, briefly, is this idea of cultural competency versus cultural humility. I went to graduate school for social work, and I think I still have a textbook. It was a textbook that talked about cultural competency. And in that book it was like a chapter on every group. There was a chapter on elders and folks, immigrants, and a chapter on LGBTQ people. And in theory, I was supposed to read that book and then feel confident in working with people, many of whom were unlike me. And so it wasn't until getting into the work that I heard the phrase of cultural humility. And I'm going to share that with you. Cultural humility really has three tenets, and it is, the first one is lifelong learning and critical self-reflection. So all of us are on this webinar today, I hope in part because we're committed to learning and thinking about the ways that we engage in the world, and in part of that learning, where can we unlearn some of the things we maybe grew up with. Also, a part of cultural humility is recognizing and challenging power imbalances for respectful partnerships. So even right now, I've got the mic, I'm talking, some folks might think I'm an expert, and I have a lot of power because I've got a room of people listening to me. And so I want to be respectful of that and offer space to be criticized and hear your questions at the end. I am not an expert for all gender expansive people by any means, and it is truly a privilege to share with you some of these tools, but keeping in mind cultural humility as we all do our work and navigate the world. And lastly, I think institutional accountability is a big part of cultural humility. So thinking about that, if you're not sure how to practice cultural humility in your individual role, what is a way that you can advocate for your institution or your workplace to be more accountable to the communities you serve? For some folks, that's hosting and requiring trainings. It might be following up on feedback, and I'll talk through some of those. But keep in mind, again, that image about gender and that we're working with some cultural humility frameworks today. For this next one, I'd just like for folks to kind of look at this picture for a moment. Again, if we're interacting, I'd ask you to notice or tell me what you notice. Often I hear from people, oh, I see a symbol for a male, I see two people behind that symbol, I see a symbol to indicate a female, I see two people behind that symbol, and then someone in the middle. And if you read the body language of that person in the middle, I often hear someone say they're nervous or apprehensive, and often hearing that they're all alone. So on this International Transgender Day of Visibility, and looking at this picture, this person might feel invisible. They might feel alone. And when a person is engaging in medical care, I think for any of us, regardless of where we're at in that system, we really want a person to feel seen and heard and cared for. I'm going to share some brief statistics that came out of the 2015 United States Trans Discrimination Survey. There were 28,000 respondents. And while you're looking at this image, I'll just share a little bit of a framework from that time. 1/3 of people who responded to that survey who had seen a healthcare provider in the past year reported having at least one negative experience related to being transgender, such as 24% had to teach a healthcare provider about being transgender in order to receive appropriate care. 15% of people had a healthcare provider ask them invasive or unnecessary questions about their transgender identity that were totally unrelated to the reason of their visit. 8% of respondents had a healthcare provider refuse to give them transition-related care. 6% were verbally harassed in the healthcare setting. had a healthcare provider use harsh or abusive language when treating them. 3% had a healthcare provider refuse to give them care that was totally unrelated to gender transition. For example, if they needed an immunization or a physical exam. 2% reported that a healthcare provider was physically rough or abusive when treating them, and 1% were physically attacked or sexually assaulted in the setting there. And again, this was 2015 that the data was captured, and at that time, in the past year, 23% of respondents reported that they didn't see a doctor when they needed to because of fear of being mistreated for their gender identity, or 33% because of cost. So I love teaching with images, just keeping this in mind again of we're trying to ensure that the people we're connected to feel seen and heard, and while this information is nearly 5 years old, I don't know how across the nation we've done to really help folks to know that we see them. So when I talk about how we see people and what opportunities we have to sort of undo this harm of that survey, thinking through, and I know Deb's going to go on to share some really great examples from Chase Brexton. What does your setting look like in terms of the welcoming environment? How are you able to convey warmth and inclusivity? What do your bathroom signs look like? How are your bathrooms made up? What's someone going to notice on your printed forms? Is it asking, is it male, female, other? Are there lots of ways? Is there a blank that a person can write in their own gender identity? How about your customer service etiquette? How are you greeting people when they walk in? Do you have to use Mr. and Mrs.? Are your patients being called by their dead name or otherwise known as birth name? How are you showing folks that you want to know their pronouns? And are you doing that consistently? Do you have signs out that talk about, feedback or, hey, I'm here to help? And if you ask for feedback, are you following up with it? I mentioned, again, visible inclusion. What does that look like? Are your images and kind of stock photos and graphics? If you're a center that claims to provide gender-affirming care, are there people that look like me in your setting? Are there people who are in your photos or your handouts or your media? And thinking of all the ways we talk about results, treatment, education, follow-up, all the different people who are going to talk to that person in the course of their care. If you're collecting swabs or if you're talking through sexual health, we'll go through that a little bit more. Just recognizing this is totally not exhaustive list, but at the end of the day, there's so much more to someone's experience with a healthcare setting than just that very short time they have with a clinical provider, and they may have walked in with a million questions or ideas to talk about when we're thinking of sexuality and their behavior, and so just holding this in mind, depending on your role in that workplace, where can you impact a person's experience? We had a talk at Whitman Walker a couple of weeks ago because we're not perfect, and we tried to also provide ongoing training and support to our clinicians. We got a lot of feedback that some of our forms weren't inclusive around sexuality or didn't leave room to talk about different kinds of behavior with different kinds of partners. So I include this so we all think about, again, leaving room to hear from people what's important to them when we're talking about sex. And I know with medical providers, we're doing more training to make sure there's room to talk about pleasure. If someone's not comfortable talking about pleasure, does that mean they're experiencing pain when they're having sex? Trans folks often feel invisible in the world when it comes to family planning, but that's a part of conversations about sex too, not assuming that because someone's on hormones that may affect their reproductive system that they don't want to have kids one day. Again, and making sure that we're also talking to people about PrEP, that we're not only talking to trans women of color about PrEP or folks who we consider to be high risk, that we're offering the same kinds of sexual health screening to all of our patients. I know Whitman Walker did a retrospective survey of some of our trans folks, I think our whole trans patient population. We realized we had under-screened folks who were assigned female at birth, so maybe they came in and identified as transmasculine or non-binary, and we hadn't as consistently been offering them the same STI test kits. So that was a huge area to improve upon. Thinking about partners and not talking to people assuming that we know who they're having sex with or the kinds of sex they're having. So in talking through what that history looks like and collecting that information, again, I think Deb's going to share a little bit more about how do you actually get the data into your system the way that you need it to when we know that our funders have requirements. We know that sometimes we have to report if it has sex with a cis male or cis female, but what about if they didn't, and how are we capturing those pieces? Several years ago, Women Walker partnered with the Human Rights Campaign to come up with this guide that talked about safer options for trans bodies, and it's available online, but it shares some of these ideas of really, when I think about this as a trauma-informed practice, for anyone we're talking to, non-trans or trans, really getting consent before we ask invasive questions, trying to ask open-ended questions, knowing that we're not assuming things and we're not, I don't know if this phrase is common, don't yuck my yum. So if I say this is the kind of sex I'm having and who I'm having it with, I want to be able to not read surprise or offense or shame on the face of the person I'm talking to, or hear a long pause on the phone in the world of telehealth. Acting consistently, so not assuming, oh, well, we talked 6 months, 9 months ago about your partners, I'm sure nothing has changed. And another big one is letting people describe the parts. We had a pelvic floor therapist come into Women Walker a couple weeks ago, and she shared her handout forms that they let people identify themselves, like, here's what I'm going to have to put in your note. How do you refer to these parts of your body? And going on from there, in a similar vein, this might be hard to read. This came up, again, it's in the booklet, but also as a part of feedback. We came up with this booklet before we came up with self-test kit instructions, and realized that our self-test kit instructions were not as inclusive as this booklet we came out with. So in the self-test kits, we said if you had a penis in your mouth or anus, and we got feedback, rightfully so, that not everybody was having sex with a penis, but that there was still risk. And so what are other ways to describe the parts that we want folks thinking through of where they're using their holes, what's going in them, where are they putting their bodies? And so this chart is a page in that booklet that I've referenced before. And our self-test kit posters are being reworked right now. We learned that the Seattle King County Public Health Department had gotten some grant funds from the CDC to actually survey trans women in their community as to how they wanted to be asked questions about sexual health and what kinds of images. And it's amazing tools. I think it's on their website that we also then were like, oh yeah, ours could change. We can show a butt, we can show a throat instead of just asking folks and using words like penis that aren't inclusive. You can use non-gender body parts, which could be all body parts, but just showing a butt can be really helpful in conveying your message. When I talk again a little bit about gaps in data collection, if your funder is requiring you to report male, female, or both when it comes to sexual partners, explore how you can have that conversation and then have that open-ended question to your patients that you don't have to be shameful, or being transparent. My funder really wants me to report data as this way. I'm going to ask you some questions. Let's get the information that is real for you, and I'll find a way to figure it out in my system. Making public health campaigns inclusive. So Women Walker shouldn't be saying if you have a penis in your butt or your mouth. We should have inclusive language that reflects lots of different kinds of sex. Visuals, I think, can really help, or having one-on-one conversations if you have a screener or a counselor and tester who can offer next steps, I think, and share that information. Having health educators or peers is really, really valuable. And then prepping for this call, it felt foolish not to acknowledge what's happening in the times right now around COVID-19. What I'm seeing a lot of in community is trans folks who feel pretty invisible right now. Hospitals across the country have canceled surgeries almost indefinitely. New patient care has been hard for folks to access. I know health centers have shut down to try to be safer while they figure out what they're doing, and that's meant someone's brand new appointment to start hormones would be canceled. And they're just like, well, when has trans care ever been a priority? All of these memos that go out with the language of non-essential. Someone's access to hormones is essential. Someone's life-changing gender-affirming surgery is essential. And I think for me as a trans person, it's been important to honor that sense of sadness and setback in my community, while also working at a health center that did rework some of our operations. And so part of my role is continuing to advocate to make sure we get folks back in, that we talk with surgeons, try to advocate and ask questions. Well, when do we think this can be rescheduled? Everyone has different priorities based on where they're at. That feels a little bit like a no-brainer, and then it also felt really important to acknowledge on Transgender Day of Visibility that trans people may not feel so visible right now, and kind of just want to leave room for that. Something beautiful that I see happening among communities is around mutual aid. I see so many opportunities to support sex workers or tipped wage earners or folks in gig economies. I think someone has done amazing research. I don't quote me on this, but queer and trans folks are more likely to be in perhaps non-traditional roles, non-salaried positions, along with other disenfranchised groups. So there's some amazing, tangible collection of goods and services being redistributed in communities. For workers, I think what I'm coaching my team around is let's check in with our patients more often. Let's let them know that we do see them, that we want them to know that we're still here, that we can try our best to meet their need via telehealth, that we're trying to be proactive with pharmacy delivery, that we, in some places, insurance open enrollment was extended, that even though it's a really scary time, that if your role or your organization's role can spend a little bit more focused energy on trans folks and thinking through where are people showing us their resilience and their togetherness as community, while also we see that if your health center's closed and if that was a place for community, that's going to be pretty sad. People are going to be bummed, much like everyone else who's experiencing the quarantine, but kind of acknowledging that for the folks we're working with, that perhaps this setback feels particularly hard in a healthcare setting. And lastly, and just quickly talking about trans-centered policies and practice, I think some of the ways that you reflect in your organizations, your waiting rooms, your signs, those are centering trans folks in gender-expansive experiences when you leave room for us on your paperwork, when we're not an afterthought, when we're not a line that says other. I'm a white person, and I can't speak for people of color, and this image is really important and something I try to include in slides whenever possible, and thinking through hiring decisions and when are we paying people for consulting, that a food card isn't always going to meet the needs of the folks, that their time is valuable, that people's expertise matters, and myself as a white person, I can't speak for people of color, so I want to make sure I'm listening to, building relationships with, paying folks for the knowledge they're sharing with me. Depending on your role, it could be as simple as listening to start, and then advocating or asking tough questions in your organization if you don't see the kind of visibility or reflection, or maybe you see a media campaign come out and you're like, wow, that language doesn't sit right with me, or perhaps a community member calls you and says, hey, this feels off, and wherever you're at, kind of floating that feedback to someone. I think giving us options, knowing that we might not, we're not a monolith, we're not all going to ask for the same kinds of care, advocating for us and absolutely trusting us to know what we need. And this didn't make the bullets, but I really value transparency. So as much as you can, communicate kind of honestly where you're at and what your org can do. that feels valuable to me. So I'll pass it over to Deb to share some more wisdom.
Our next presenter.
Hello. Can you hear me? Hello?
Yes, you can go ahead.
Okay.
Yes.
Hi,
yes,
I'm
we
Deb
can hear
Dunn.
you. You can go ahead.
I'm Deb Dunn. I'm a family practice physician assistant at Chase Brexton. My entire practice is transgender and gender non-binary. My youngest patient is 6 through 8, and my oldest is 60s, 70s, and 80s. This is my 11th year of my slides aren't moving. Let's see. Not able to get my slides to move. Okay, here we go. I'm sorry. This is my 11th year of practicing transgender medicine, and I want to introduce you to two basic terms that I use basically just for teaching, but not really outside of teaching. The first one is AFAB, which is assigned female at birth. The second one is MAAB, male assigned at birth. I'm going to be referring to these two terms throughout my talk because I honestly believe, from working with transgender and non-binary patients for the past 11 years, that people really do realize and know their gender from birth. But there was a doctor when they were born, looked at their genitals and said, you got a boy, you got a girl, raise them that way, teach them to marry someone of opposite sex. But I do honestly believe that these people know their genders from birth, just like anybody's, just like mine, just like yours. I really like what Charlie has to say in this slide. I wasn't born in the wrong body. If anything, I was born with testosterone deficiency that my primary care physician was happy to prescribe for me. And I really honestly believe that the transgender non-binary people do not believe that they were wrong in bodies. They were born in the right bodies. They were assigned the wrong sex at birth. And slides. The gender non-binary patient, that seems to be the most misunderstood amongst practitioners that I teach. This is Rachel Ann Williams. And what gender non-binary, genderqueer, other terms that people use that Britt explained to you, what they really want you to understand is that they are not always wanting to appear androgynous. So they're not always looking male and female or switch up day to day. As you can see from Rachel Ann here in this slide, her presentation is very femme. She uses she, her pronouns. Gender non-binary people don't always use they, them pronouns. So I walk in the room with our patient. I say, my name is Deb Dunn. I'll be taking care of you today in your name. And then I ask pronouns and I ask gender. And then I refer to those people using that name and the pronouns. Because as Britt said, when you don't, it can be very triggering. It can trigger a dysphoria that causes a person to feel hurtful and devastated. If you use names that people do not assign their self or the wrong pronouns, you can actually lose that patient. That patient may not ever come back to see you again. So to provide safe space, it's really important from the beginning that you get the name and the pronouns right and that you get it right every single time. Gender non-binary people do have dysphoria. Dysphoria is that doesn't align with the way they feel on the inside. Just like transgender people, though not all trans or non-binary people have dysphoria, not all want to be on hormones, and not all want surgeries, but some do. I'm not going to go into sexual orientation, teaching you what these words mean. I just want you to know that it's important that you realize that transgender and non-binary people do identify as asexual, bisexual, gay, heterosexual, lesbian, pansexual. So what I've learned to do is to ask people, instead of what is your sexual orientation, I ask, who are you attracted to? Because that I've learned that gives me a broader spectrum of a person's orientation. So if a person says that I'm a lesbian, but I am attracted to women and men and transgender, then I have a broader picture. What I find happens when we start medically transitioning transgender and non-binary people, and they do start aligning with the way they feel on the inside, then they feel more comfortable being in romantic and love relationships with people from other genders. And so you can see some change and some shift happening in sexual orientation. 2 MAABs, males assigned at birth, who identify as women, trans women, gender non-binary women who are in relationships may identify as lesbian. You also, I don't want you to get caught up in these terms. If someone tells you they're lesbian, not asking sexual questions like, are you having penile penetration or are you having sex with males? Because some people don't identify as bisexual but just enjoy the having sex with the girl-on-girl sex, but not necessarily identify as lesbian. So try to get away from using the terms, but ask people who they're attracted to. Collecting SOGI data, as Britt said, is so important. We need to be able to identify on forms and our EMR systems gender other than just male or female. We need to be able to collect this data so that we can start looking at health disparities that impact this group of people. Like a lot of health departments do not know how many people in their county or in their city are positive for HIV that are transgender or gender non-binary, because they're still just collecting data on male and female rather than allowing people on their forms to identify as transgender or non-binary. So it's really important that you do this, that your forms are reflective, people are able to check their gender identity and orientation, and that we're able to start measuring the health disparities that are impacting this group of people. It's so important that you try to stay away from, try to use gender-neutral words like parents and not using mother and father on forms, that you're using spouses and not husbands and wives. This gender history sheet is part of our EMR system. If you look at the bottom where it says sexual history information, the drop down that says gender identity has several different options. It says transgender female to male, male to female, gender queer, so forth and so on. It's so important that this is you're able to document this in your EMR system. This second page is our sexual history sheet. So if you look at your top left where it says sexual activity, I usually ask, are you in a relationship? Are you sexually active, yes or no? If they say yes, I ask about the gender of their partner. They could say gender queer. They can say male, female. And then I ask who they're attracted to. So important that as practitioners, you get comfortable asking sexual behavior questions. Many of you are comfortable asking questions like penile penetration, oral sex, anal sex, but I know a lot of people aren't trained on how to ask sexual history questions on two female genital people who have sex, like vaginal to vaginal sex. We know that HIV, chlamydia, gonorrhea are transmitted through mucous membranes, urethra, rectum, vaginal, and oral, but not so much with two partners who have vaginal to vaginal sex. Who are these people? They're people who are AFAB, assigned female at birth, who identify as transmasculine people, which is the sexual act. It could be more skin-to-skin contact, which you would be seeing more syphilis, herpes, HPV being the number one STI transmitted between two people with vaginal sex, which should tell you that the importance of trans men having pap smears. So it's very comfortable. Doctors are still stuck and not comfortable with feeling comfortable asking sexual history questions. Very important. HIV, transgender, especially transgender women of color now, are up there. Number one was HIV. This was a study that was done by the Center of Excellence for Transgender, 27,000 respondents. We're now seeing that a higher number of transgender women are HIV positive. And I'd like to bring your attention to the second bullet from the bottom that says more than half, 56% of Black African American transgender women are living with HIV. That's actually more than 1 out of 2. You know, we keep hearing this, we're winning the war on HIV, but it really is hard for us to realize that we're winning the war on HIV if we're still seeing statistics like this, 56% of Black African American transgender women. It almost feels like no one's paying attention to this group of people. It could feel like treatment bias. The last bullet, new HIV diagnosis, was more than 3 times the national average. Well, this is startling. This is like, why aren't we paying more attention and realizing why it's so high in this community of people and not addressing it? Some of the factors that lead to increased HIV in trans women, we know sexual, anal sex, vaginal penetration, which is what transgender, trans female identified and gender non-binary people do engage in top and bottom penetration and giving penile penetration. Also, there's a lot of online dating hookups. Transgender women particularly share needles to give each other their hormones. We know that there are people who share needles to inject silicone to help feminize breasts and cheeks and hips and thighs. These are all ways that HIV can be transmitted. So when you're counseling your patients that you're prescribing hormones for, please help them to realize that this is a way that HIV is being transmitted. This slide came from the CDC. HIV diagnosis among transgender people based on race, the big orange circles, you can see they're Black, they're transgender men, it's 58%. Transgender women, Black, makes up 51%. So again, you know, if you're seeing these patients in your office, you should have a high suspicion that you should be checking and testing them for HIV. I have my patients come back every 3 months who are at risk, and I check them for chlamydia, gonorrhea, syphilis, and HIV because I know that it's one of the top 3 health disparities in this group of people. Why is the disparity so high amongst the Blacks compared to the other smaller portions of the graph? Well, if you look at this study, the Strove study from Hopkins, look under social economics, the social determinants of health, unstable housing, and income below poverty level and unemployment, these numbers are very realistic. 57.21% are homeless, unstable housing, 75.79% of people live below poverty level. How are we going to help fix this is health departments, HRSA, federal government fundings are going to have to address the social determinants of health. They're going to have to help improvement, housing, people getting jobs, improving the poverty levels. We know that stigma, discrimination, biases, stereotypes still happens in the transgender community. I'm able to medically transition my patients, but unfortunately, I have no impact on the discrimination that they face every day, the rejections from family, which is up to still 40 to 50%. There's in the impact of these stresses, we know that that transgender people walk around with this stress, this fight or flight feeling of not realizing when the next act of violence or discrimination is going to happen. And the impact of that is mental health, anxiety, depression. Still 1 out of 2 transgender and non-binary people attempt suicide, with 93% attempting suicide before they're 25. We know that this kind of fight or flight stress causes elevated blood pressures and blood sugars, chronic pain. Why do I keep having headaches and nobody can find out what's wrong? Access to care is still poor. Access to competent care, doctors not understanding or knowing how to treat transgender people, or just right out saying, I don't want them in my practice. So what are some of the health disparities? HIV definitely is one of the health disparities, which is a result of this. So I did put a lot of slides in here I want you to go through and look at later. It's a lot of data about discrimination. We know that transgender women, especially of color, are being murdered. People are having a difficult time getting jobs. 90% of people going to school are harassed about their sexual orientation. No wonder kids don't go to school. So you can see from these slides that there's still a lot of discrimination and biases. Last of all, take the next 3 minutes to talk about PrEP, because PrEP has been known as that thing that's been successful in helping fight the war on HIV, but let's see how it's working in the trans and non-binary community. Basically, the next data that I'm going to discuss with you comes from these 2 studies, the LIGHT study and this one, findings from mixed methods research on HIV prevention among Black and Latino women. Both studies were done at Hopkins. So what I'm seeing in my practice and what this study shows is that people do not take PrEP, and the number one reason is because they believe it interacts with their hormones. It's very validating when a person tells you that they stop taking their hormones because they stop taking PrEP because it's stopping or slowing down their transition. Side effects is up there, not wanting to take a pill or taking a pill like as needed, which we all know doesn't work. Just talking and having conversation with your patients about the importance of taking it every day. People are concerned that folks may think they have HIV if they take an HIV medication. A lot of advertisements are geared towards men who have sex with men, where transgender women are not men who have sex with men. And this study just basically shows that PrEP is not supposed to lower the feminizing hormone levels. But as we know, dysphoria is not usually, there's not an arm for measuring dysphoria in these studies, which there should be. Because if a person becomes more dysphoric as they take a medication, they're not going to take it. This graph shows PrEP continuum amongst adult and youth. The darker green is adult, the lighter green is youth. We're seeing that youth are having sex just as much as adults are. 83% are aware of PrEP, so we're doing a good job at educating. Only 23% have ever taken PrEP. But look at the last column, only 9 to 8% adhere to PrEP. So it doesn't look like PrEP is too much of the solution for fighting the HIV in this group. So amongst people who were willing to take PrEP were people who engaged in exchange work, sex work, who knew that their risks were higher. But even still, this group, we know that there's poor compliance, missing doses. Barriers to health care with PrEP, again, comparing youth with adults, we clearly see that there are barriers. The youth, even though it's been approved by the FDA, and also some states are allowing doctors to prescribe PrEP without parental consent. It's just these kids aren't going to take a pill every day. How are they going to get to the doctor's office every 3 months? These are all barriers still for adults and children. So you've got to design programs around calling these kids, calling your adults, checking in when they're having the pharmacy call you when their prescriptions are late being filled. Doctors, you got to get away from this transphobia and racism, the stigmas around HIV. It's so important to prescribe PrEP. So addressing PrEP barriers, please have a discussion, have opening and affirming areas where your people can come and feel comfortable being prescribed PrEP. Best practices for HIV prevention, develop partnerships with trans people and organizations to create and grow program services and research, hire transgender people to work in your offices, have focus groups where trans and non-binary people can tell you what the needs are in the community. I know one of the ways that Trace Brexon is so successful at this is because we're multidisciplinary. We have behavioral health. We have nurses. We prescribe our hormones. We have dentistry and GYN all in one central area that's opening and affirming. So that is have to be one of the best models that you can use. So I am going to stop. I do have a lot of slides that you can read, a lot of information to help build your PrEP and your HIV program with trans and gender non-binary people, but I do want you to have time to ask some questions. So I'm going to stop now. Hello?
Hi. Thank you so much, Deb. I'll just leave your contact info up for a while. Okay, so we're going to take a few questions from the chat box. I believe one of the first questions that I saw was about the form that Britt presented on. Britt has already sent me the link for it, so I will be sending that out to the registered participants, and we'll also try to see if we can add that to our website for resources. And then I want to say our next question is, one second, from Isaac Wade, and this is to either presenter Britt or Deb. Why is it considered important to document age of first sexual intercourse in the EMR? They also said, I think that might qualify as invasive, medically unnecessary piece of data. Do funders require this? Why would it ever be necessary? And you can press * pound to unmute yourself, Deb or Britt.
I never asked that question. I never asked that question. And, you know, the only time anyone should be asking people about being sexually active is if you're needing to counsel them about sexually transmitted infections and birth control. Honestly, that's the only time I think anyone should be, unless you're going to be dating a person and you're interested in knowing their sexual orientation. I think that it's very personal who you're having sex with.
Thank you, Deb. I would also follow up. The only time I've ever had to ask that question as a DIS was for a patient that let me know via conversation that they recently started having sex. And so in order to figure out what all screenings that they should have and things like that, I did have to follow up and say, like, when did you start having sex? But that was because the patient prompted and we were trying to figure out all their partners. Otherwise, like, if it's someone that's, probably been having sex for a while, or if it doesn't come up in conversation, in my experience, I haven't seen that question be necessary or something that you have to include in your EMR. Our next question is, how do you not make assumptions about body parts based on partner gender identity, or make assumptions about sexual behaviors based on partner's gender identity? I don't see how knowing partner's gender identity matters in sexual health conversation if ultimately the conversation is around sexual behaviors. I know that Deb kind of just mentioned that a second ago. I didn't know if you had anything more that you wanted to follow up with about it, or if Britt had anything that they wanted to say.
I ask about sexual attraction, and I do, as medical professionals, number one, a way to identify the LGBT community is asking about sexual orientation kind of questions, which we know now there are certain risks, higher risk that people are that are in the LGBT community. So to help me identify who the LGBTQ people are, I do ask about, sexual identity questions, but also knowing sexual behavior. Because I just test everybody for everything. I test everybody for GC, chlamydia, HIV, and RPR. But, there's certain dialogue you wouldn't have with a certain person. Like if your patient was having sex with two males and a female, but they were all assigned female at birth, you may not have a discussion about birth control, for example, if your patient is cis female or assigned female at birth herself. So those are the only, like I said, those are the only time when I'm, medically looking for health disparities that I need to address with the patients. Do I ever ask those questions to?
This is Britt. I would just add, I've been in uncomfortable medical visits where I get asked that question: do you have sex with men, women, or both? I have multiple partners. Let's say I have a partner who's a trans man who their identity is they're a man. Would I fit into that category if I say, oh, I have sex with men? So I think for me, it just highlights that there should be open-ended questions, and that clinicians or whoever's asking these screening questions should try to have open-ended questions, or say, here, if the ultimate goal is the person's there to understand their risk or to get education, then it's talking about what are the tests you're going to run, how do you test them, is it making sure everybody knows, everyone gets a urine sample, that's where we look for chlamydia and gonorrhea. We can also test for chlamydia and gonorrhea in your butt and in your throat. If you're having sex in your butt and throat, go ahead and swab those also, and kind of leaving that up to people to decide for themselves. So I hope that answered your question.
Thank you. The only thing I would say that is for the clinical setting, for the DISs on the line, as far as partner services go, to follow up with what Britt said, then you would just leave the questions open-ended. Like my DIS forms, like the interview prompt questions would always say like male, female, but I would take the directives to say what genders are you having sex with, so that would help me identify their partners. And then I would also just ask more open-ended questions about the sexual behaviors. When you have sex, could you describe that experience for me so we can figure out how you may have been exposed? If you have any type of DIS questions, well, I think there's also a link for the DIS Slack channel and how we can definitely follow up with that as far as the interviewing style for partner services. Something else. Oh, hold on 1 second. I know someone raised their hand. Larry Haynes, if you want to go ahead and ask your question, you're just going to press star and the pound sign to unmute your phone. Okay. If you're not able to unmute your phone or decided not to go ahead and ask your question, our last question really quickly is, what are considerations around specialized clinic hours for trans medicine? Is it more advisable to have trans medicine completely integrated with sexual health services in a low-resource public health environment, noting that hormone treatment is not approved in our setting? And this is coming from Bud Strechter, a data analysis at the Baltimore City Health Department.
Can you repeat the question?
Yeah. So what are considerations around specialized clinic hours for trans medicine? Is it more advisable to have trans medicine completely integrated with sexual health services in a low-resource public environment?
It is very integrated at Chase Brexton. We we see primary care and we see family practice. So we see children, we see non-trans, non-LGBTQ people. So it's as integrated as everybody else's. There's no specific time. We do have people that specialize, however, in gender therapy. They're gender therapists. And all of our providers are able to take new trans patients, are able to prescribe hormones. They go through a 3-part medical training on how to prescribe the hormones. We do have a pediatric endocrinologist that starts the puberty blockers. It's very integrated. We're not asking sexual questions at every office visit with every patient. We address the immediate needs of the person, but it's very integrated. We don't have separate sections for LGBTQ people.
I would echo that. As much as you can be sensitive to your environment, and if you're going to say we're trans affirming or gender affirming, and then you're not, just thinking through that. But ideally, integration, I think, is best, and really making sure your environment is supportive.
This is our very, very last question because I know we're running a little bit over time. Nick Love said, do you think it is helpful to have specific drop nights for transgender and non-conforming folks?
We have several at Chase Braxton support groups, gender non-binary support groups, gender non-binary people of color support groups, trans Zendence, which is a support group for people just starting hormones. We have support groups for trans non-binary people living with HIV. We have a huge program for elders, LGBTQ elders who often are just growing older in isolation. So, yeah, we do offer a lot of support. Plus, we have a lot of relationships with people in the community, community partners, other trans organizations. They come in. We do focus groups. We work with the health departments, for example, in designing programs to help with Narcan and overdoses and HIV, and we have a pharmacy that's 340B, so we're helping people get medications. We offer a lot of support systems.
Can I respond to that really quick? Also, yes, having gender expansive services that are supportive and any kind of service at that times that work for folks. I think if it's your whole programming, trans folks should be able to access affirming care amidst non-trans folks and, without it upsetting your programming. So, we shouldn't have to use a separate door kind of thing. But I think additional services, if trans folks can access regular hours and you say, hey, we want to have a special night that we bring lots of information and we stay open for 2 hours to add additional information and support, that also can feel good. Not every trans person wants to be told, well, you have to only access care on Thursday evenings from 6 to 8. Just throwing that out there.
Thank you, Britt and Deborah, for this wonderful webinar. At the end of this recording, the recording of the slides will be available to you. I will be emailing that out to everyone that registered, and just like all our other webinars, they are available on our resources page on ncsddc.org, and this webinar will be available soon. Also, there is a survey. I see that everyone has quite a few questions. The survey does allow you to write a free response, and go ahead and please let us know if this is like a webinar or something that you would like more technical assistance with. And you can also reach out to us for technical assistance. And as I said before, as the presentation is being emailed out, the contact information for both Deb and Britt is available to follow up with them. Thank you so much. for joining this meeting. I hope everyone has a really wonderful day.
Thank you. Take care.